So next is gastric volvulus, 75-year-old female with non-diaphragmatic hernia, presents with severe retrosternal chest pain. Cardiac investigations were negative and she has lactate of 3. Discuss your initial management of this patient. So give analgesia, IV fluid, and then take history, do FBC, UNEs, LFTs, amylase, CRP, cardiac enzymes, and do 12 ECG and direct chest X-ray. The test results show a mild leukocytosis and slightly elevated CRP of 32. Cardiac enzymes are within normal limits. ECG shows sinus tachycardia rate 101 without any ischemic changes. Chest X-ray reveals a widened mediastinum, unclear left cardiac border, and air fluid level above and below the diaphragm. Repeat lactate after 1 liter intermittent fluid is 3.8. What are the possible causes for patient symptoms and how would you further investigate this patient? The pre-existing history of heterocynia, patient symptom, and investigations are all highly suggestive of gastric volvulus. Other causes may include thoracic aortic dissection, a ruptured esophagus, brochured striate of upper abdominal pain, vomiting, and difficult to pass NG. Describes the classical presentation of patient with acute gastric volvulus. The diagnosis can be confirmed by contrast imaging of the stomach, such as the CT thoracic abdomen with the wart-soluble contrast or gastric and swallow. In this scenario, CT scan with IV contrast and on-table gastrogloffin would be the most useful investigation, as it will allow diagnosis of gastric volvulus and help rule out a ruptured thoracic aneurysm. A CT thorax abdomen is performed and confirms gastric volvulus. What is a gastric volvulus and how can they be classified? Gastric volvulus is a condition in which the stomach rotates 180 degrees. The rotation may be along the axis of pylorus and cardia, called organoaxial rotation, or along the lesser greater curve. Pylorus, cardia, lesser greater curve is called mesenteroaxial rotation. Organoaxial volvulus is the most common type, accounting for 60% of the cases. What is the management of gastric volvulus? So in emergency setting, the treatment is aimed at reduction of the volvulus to minimize compromise to the gastric blood supply and relief of the obstruction. This can be sometimes achieved by incision nasogastric tube and decompression of the stomach, which may allow for spontaneous resolution of the volvulus, or if it is not possible, endoscopic decompression, so OGD. And if there is a concern regarding gastric ischemia, then surgical intervention is necessary. Surgery involves volvulus reduction, reintegration of the stomach into the abdominal cavity in cases of intrathoracic migration, and correction of the causal factors. Resection of the hernial sac and role of gastropexy for preventing recurrence remains controversial. Thank you.